Hello and welcome to this webinar on sleep problems in veteran and military populations. A very warm welcome to all of you who've joined us for today's live activity, and I'm actually not exaggerating when I say we have people from all around the world, so a very warm welcome to all of you. And I think the number of people that have joined us today is a testament perhaps to just how important these problems are. Welcome also to those of you who are watching us later on a podcast or on a listening to us on watching us on a video cast, and a very warm welcome, of course, to our panel, who I will introduce in just a moment. First, I'd like to pay our respects to the traditional custodians of the lands across Australia upon which our panel and our participants are located. I'd like to pay our respects to their elders, past, present and future, and I'd particularly like to acknowledge all the Indigenous men and women who have served in our Defence Forces over the years. Sleep problems, I think, are very common, and I guess most of us at some stage in our life will have some kind of difficulties falling off or staying asleep. But of course they can become very severe, they can become very debilitating. And today we'll be hearing about the different kinds of sleep disorders that people may experience. We'll hear what it's like to have those disorders and the impact on the person and indeed on their families. And we'll talk a bit about what we might be able to do to help and what kind of treatment is available. My name's Mark Creamer. I'm a professor in the Department of Psychiatry at the University of Melbourne, and I'm also a clinical psychologist in private practice. I have a very long interest in the mental health effects of trauma and a particular interest in veteran and military mental health. And when I see clients in my clinical practice, very, very often they talk to me about sleep problems. And so I'm thrilled today to be able to draw on the expertise of this tremendous panel that we have with us today. So without further ado, let me introduce them. I'm going to keep it fairly brief because there are full biographies on the website, which I'm sure many of you have read already. So I'll keep it brief. But first, I'd like to introduce Flight Lieutenant Brendan Notke. Brendan joined the Australian Army in 1993 and transferred across to the RAAF in 2007. He trained initially as an avionics technician and then later as a logistics officer. He's been on many deployments and he's currently serving as the Senior Recruitment Officer in Darwin. So thanks for joining us, Brendan. Welcome.
Thank you, Mark.
I must say that when I think of Darwin, the first thing I think about is hot, sweaty nights, and I guess that kind of weather, especially in the summer, must make it a bit difficult to sleep in itself, doesn't it?
You are correct, and we're just coming up on what we call the build-up, which means everything starts to get more humid but no rain. The most difficult thing about Darwin nighttime sleep, though, is not so much the weather, it's the fireworks. We have one day a year where we're supposed to release fireworks, and then we have some other days where some folks get a little bit excitable, and that makes night times a little bit interesting occasionally.
Wow, I can imagine. And taps into some stuff I'm sure that we'll be talking about a bit later about hyper-arousal and being on edge and jumpy and so on. We'll come back to that. But thank you very much, Brendan. Sean Drummond is Professor of Clinical Neuroscience at Monash University in Melbourne. He's been researching sleep and sleep disorders for nearly 3 decades. He grew up in America and spent most of his career working in the Veterans Health Administration in the US. But in 2014, he finally saw the light and he moved to Australia. So welcome, Sean. Good to have you with us.
Thank you very much. It's my honor to be here.
So, as I said, you've been working in this area for a very long time. What got you interested in sleep?
It was a bit random luck, actually. I was a second-year student at uni, and I was interested in science and wanted to volunteer to do some research, and saw a sign in the hallway that said volunteers needed in the sleep lab, and I thought, oh, that could be fun. Next thing I knew, I'd fallen in love with the field and spent my career there.
Interesting. This serendipity, isn't it? Often the smallest decisions actually turn out to affect our whole lives. Thank you very much, Sean. And our final panelist is Jennifer Veitch. Jennifer is a psychologist with many, many years of experience of providing psychotherapy and other mental health services to serving personnel, to veterans and to their families. She is currently Director of VVCS for New South Wales and the ACT, and was previously Director of VVCS for Far North Queensland. So welcome, Jennifer. Thank you very much for joining us.
Thanks, Mark.
And I was thinking I should probably have asked the others this question as well, but I didn't. So let me put you on the spot. How's your sleep?
Not too bad at the moment, but it's very interesting. A bit of throwing a bit of performance anxiety and, a couple of sleepless nights, and here I am. So if I nod off, you'll know why.
Indeed we will, and I'm sure that you won't. But thank you, Jennifer, and thank you to all our panel. Before we get started, I just need to run through a little bit of administration kind of stuff. If you've got any technical difficulties, I hope that number is on your screen now. 188, I've got 1-800, but anyway, 733-416. And they will be able to talk you through any technical problems you have. In terms of the structure, the webinar is going to go for about an hour. We're going to have the first half, the first 30 minutes, with our panelists doing a short talk each. And then the second half, we're going to break open for questions and answers. Many of you have already submitted questions, and we've had some tremendous questions from you, so thank you very much for that. But you're also able to submit comments and questions through the webinar as we go along. They'll come up on a small screen in front of me, and we'll be taking those as well. You may have to bear with us. We will try to get through as many of your questions as we can, but if we're not able to, please bear with us. The good news is that VVCS is going to collate all the questions and will provide brief answers to each of them. So if we don't get round to it today, then in due course you will receive that from VVCS and have your question answered there. We're also recording the this webinar, and that will be available in about a week, and VVCS will email you with a link to that video, and it will also be advertised on Facebook and Twitter and that kind of stuff. So please feel free to forward that to your friends and colleagues so that they can also watch or listen to the podcast. And finally, can I ask you not to forget that at the end of the webinar, we would really like you to complete a feedback survey, a very brief survey, to help us evaluate how successful the webinar has been. So that out of the way, I'd like to hand over to the first of our panelists, and I'd like to ask Brendan to talk to us a little bit about what it's like to actually experience some of these sleep disorders and perhaps the impact on himself, and maybe a little bit about whether you tried to get some help. Brendan, over to you.
Yes, thanks, Mark. So for me, it started in childhood, where I did have some parasomnias. I recall a couple of incidents. I've mentioned toilet football and window climbing, where there was one incident where I was caught outside the toilet, actually in the dummy half position, ready to receive a football. No idea why. There was another time where I was climbing out of a two-storey window. I had my leg out the window when Dad came into the room and went, "What's going on here?" It's interesting because when I joined the Army in 1993, clearly we would understand that the military is fairly rigorous in lifestyle. Training is important, but most important of all is deployability and the ability to operate in a warlike environment. And it was not something that was in my life at that point in time. I had no parasomnias, I had no sleep disorders. There was one incident in Tully in 1995 where I was in the jungle and I woke up when we were being attacked, a fake attack, as part of our training, and I was actually facing the wrong direction with my rifle, with no threat to anybody, but really had no idea where I was or what I was doing. And that is the only recorded experience that I remember out of nearly 15 years of service up until the problem started again, where I had nothing occur. So in some other life events that have occurred since my joining the Defence Force, I had a marriage breakup in 2002. That's obviously a high stress incident. I had some deployments I went on, East Timor, Banda Aceh, the Sumatra tsunami relief. That was fairly stressful. I had a lot of field exercises I went on. I had a bit of a drinking culture, which is common in Australia, I suppose, in some ways, but no real sleep disorders through that time either. I was a busy man. I was fatigued. I transitioned to officer, and I think that's when things started a little bit for me. I went from a very physical lifestyle to an intellectual lifestyle. Now, me today, I have a young family. I have a 3-year-old and a 10-month-old. I have a fiance. I've been with her for almost 8 years now. And I live a lifestyle where my workload is more with less, like many of us do now have in our worlds, where we have to achieve more with less resource. And I've noticed in the last few years now I'm starting to have parasomnias again. Some of the examples I'll give are pretty bad. And I was talking to my fiance about it last night just to refresh my memory. Examples would be where I woke up in the middle of the night and I was actually pulling apart a bedside lamp and I had bared the wires in the lamp, which was still plugged into the wall, of course. I've woken up when my fiancée was pregnant with our first child, I've woken up actually assaulting her in bed. And for me, that's a deeply traumatizing event, incredibly painful for me to relive that in my own mind, because that's totally against everything I stand for. That was the first occasion where I self-referred. I went straight to medical the next day and said, I've got a problem. I've done some other silly things that you can have a bit of a joke about. I've chased spiders around the room in the middle of the night, and there's no linkage between that and my day-to-day life. There really isn't. I've self-referred a couple of times in the last few years. I've been to different testing. I've had neurological tests. I've had time with therapists, time with psychologists. I've recently completed a sleep study, which was my second one. And the diagnosis we got out of that was parasomnia and sleep apnea. Now, I've got to take action on the sleep apnea side of things with a dental RAM or something it's called. But a lot of this is also built on other things and has resulted in other things. I have fear and anxiety towards my career. I have fear and anxiety towards my family. I am very, very anxious for my family. My fiancée is under constant stress with my behaviours at night time. I have been given clonazepam, as the drug I should take at night to try and settle me down. But I tend to find, or my fiancée tends to find, that I still have the parasomnias and I still have the difficulties, but I'm just harder to break out of those. She finds it more difficult to wake me up. So I have effectively sought a lot of treatments. The Defence Force has been fairly supportive in that way, and that's been great. But that's for me. My partner doesn't really get the support yet, but we're pursuing that through VPCS. And I think the main point that I would like to make at the end of what I'm saying here is that the biggest thing I can do for myself is to try and change my routine. That's always been the advice given to me by all of the specialists is I have to adjust my lifestyle, in the evenings especially, to try and counter the problems that I've either have been inflicted upon me through stress and lifestyle, or I've self-inflicted. And that's kind of where I'm at now. I'm at a point where I'm making change because all of this is very recent, a lot of the studies and such, but the threats at night are real. The parasomnias are real, and the concerns I have for my family are very real.
Yeah. Thank you very much, Brendan. That was very interesting. In fact, you were talking there about routines and lifestyle and so on. We've actually just had a question coming in about playing computer games in bed, but we'll come back to that later. It's on my list of things to talk about. I was interested also in the fact that you talked about onset in childhood and so on, and again I'd like to talk later about how things change across the life cycle. But the questions I did strike me were about outcome, and I guess I've got a couple of questions. One is, what would you define as being a good outcome for you if all this treatment was successful? What would be a good outcome? And secondly, do you think you've got there?
So I'll start by answering the second part. I'm not there yet. I'm definitely not there yet. 2 nights ago, I was walking around the house in a violent manner while my fiancée had our 10-month-old, and I have no real recollection of that except for waking up partway through that and arguing with her. So the outcome from a personal perspective is I'm not there. The outcome from a treatment perspective is I have a path forward. I have a path forward for me that I'm starting to process, and we have a path forward for my partner who has not really had any opportunity yet, and we were talking about this earlier, through VPCS and other options. The outcomes, though, are driven by the need to just stop being violent. That's my critical priority. Is I can sleep talking and things like that we could handle as a family, but the violence and the concern of me getting up in the middle of the night with no control over my own body, those things are important. The fact that, as an example, I'll have what my partner calls daddy narcolepsy. So at about 6 p.m. every evening, I'm kind of looking to lie on the floor and snooze because I'm just fatigued. And I wake up in the morning to get up to go to work, and I'm fatigued. I'm fatigued every day that I go to work. And we're working at trying to reduce what I do in the evenings to allow me to progress into sleep better, to be able to have a more robust sleep, to get out of that cycle of violent behaviour or parasomnia, but also to at least wake up a bit more refreshed.
Yeah. So you've got some way to go, I guess.
I've got a long way to go, but there is a path.
Yeah.
There is a path.
And that's reassuring to know that there's a path, I suppose, that there is a way forward. And I can understand entirely. It must be terrifying, not only for you, but also for your family when these things are happening in the night. So we'll come back to those and talk a bit more about that. Thank you very much indeed, Brendan. Much appreciated. I'd like to hand over to Sean now to talk a little bit about the research studies and I guess what the evidence tells us.
Yeah, sure. Thank you, Mark. So what I'm hoping to do really in my couple of minutes is just provide a broad dot point view of what science tells us about the way that sleep interacts with some of the main issues faced by veterans and active duty personnel. Before I launch into that, though, I want to quickly cover this first slide, which is just talking about the different stages of sleep, because it turns out sleep is actually not one state of consciousness. Sleep is actually two distinct states of consciousness. One of them that we call non-REM sleep, and the other that we call REM sleep. And folks have probably heard of REM sleep. It stands for rapid eye movement sleep. It's the stage of sleep in which we do most of our dreaming. Non-REM sleep, the other state of consciousness, is further broken down into three stages of sleep, stage 1, 2, and 3. The bigger the number, the deeper the stage of sleep, so that stage 1 is really this transition. I don't really know whether I'm awake or asleep stage of sleep. And stage 3 is the really deep, I'm sleeping like a log, it's hard to wake me up stage of sleep. And when we get lots of stage 3 sleep during the night, we wake up feeling rested and refreshed and restored. And the consequences of sleep disruption in part depend on which of these various stages of sleep and states of consciousness are disrupted. And we may get into that a little bit later. So my particular specialty, as Mark mentioned, is the interaction of sleep and mental health. And what we know is that sleep and mental health issues really have a bi-directional relationship. So it's very common that if someone is experiencing some mental health difficulties, depression, anxiety, PTSD, whatever it is, that will result in some sleep problems. But what we quickly find is that the sleep problems, particularly in insomnia, will take on a life of its own and become its own independent disorder that requires its own independent treatment and attention. And not only can a mental health problem initiate a sleep problem, but maybe even more importantly and less well known, is that sleep problems, particularly insomnia, actually put somebody at risk for developing mental health disorders. So if somebody has insomnia right now, they are at risk of developing a new mental health problem down the road, even if they've never had that mental health problem before. And when sleep and mental health problems exist together, the daytime symptoms of the mental health problem are made worse by having the sleep difficulties at night. And this connection between insomnia now increasing the risk of a mental health problem down the road are strongest from a data perspective for depression, for mania, which is also called bipolar disorder, for post-traumatic stress disorder, substance abuse, and suicidal thoughts and behaviors. And I think it's worth noting as well that not just insomnia, but nightmares in the aftermath of a trauma exposure also predict the onset of PTSD down the road. Now, not only does insomnia now predict the onset of a new problem, but if somebody has a mental health problem, but they've been treated or for some other reason they're in remission right now, they're doing really well, the development of a new episode of insomnia is often one of the early warning signs that they're at risk for relapse. And that relapse risk related to sleep is particularly keen in depression, mania, alcohol dependence, and psychosis like schizophrenia. Now, I want to touch just for a minute on two areas that are really common in active duty and veteran personnel. The first is post-traumatic stress disorder. Of course, sleep is really messed up in PTSD. There's no really other way to put it. Upwards of about 90% of veterans with PTSD report sleep difficulties. Something like 70% of civilians report sleep difficulties. Clearly, insomnia is one of the major nighttime symptoms of PTSD. And the nightmares that you see in PTSD or rather PTSD is probably one of the only mental health problems that's characterized by frequent chronic nightmares, whereas you don't see chronic nightmares so much in the other mental health disorders. Now, one of the interesting things from a science perspective is that every study that has looked at sleep and PTSD says, yep, sleep's messed up in PTSD. But every study also seems to say a slightly different part of sleep is disturbed within the context of PTSD. And so our group has actually recently done some research, and what we are proposing is that the reason studies have inconsistent answers is because the hallmark feature of sleep difficulties in PTSD is actually night-to-night variability. That is, sleep is extremely unpredictable, and somebody with post-traumatic stress disorder going to bed doesn't know, am I even going to fall asleep? If I do fall asleep, am I going to have a decent night of sleep or a bad night of sleep or a really horrible night of sleep? And that inconsistency is the most consistent thing about sleep and PTSD. One more interesting note is that the rates of obstructive sleep apnea that Brendan was talking about just a minute ago are much higher in PTSD, even when somebody doesn't otherwise meet the stereotype of somebody who has obstructive sleep apnea. And then finally, of the stages of sleep that I was talking about earlier, REM is the one that's most related to PTSD, and not just because nightmares happen in REM, but we know that from a biological mechanism perspective, disrupted REM sleep is actually involved in some of the physiological processes that underlie the daytime symptoms of PTSD, particularly these very basic fear and extinction and safety processes that go awry in post-traumatic stress disorder. The last thing I want to touch on is chronic pain. This is another condition, medical condition in this case, that's very common in veterans. Something between 50 and 80% of people with a chronic pain disorder also have chronic insomnia. And just like with mental health, there's a feedback loop between pain and sleep. And so having pain, of course, makes it harder to sleep at night. Getting disrupted sleep at night makes somebody more sensitive to pain the next day. That pain sensitivity makes it harder to sleep at night, which gives you more pain during the day, and it becomes this snowball rolling downhill. Now, the really good news with that, though, is if we treat sleep, which we can do very successfully in the context of chronic pain, particularly insomnia, we can get that snowball rolling the other direction. So if we treat sleep and people are sleeping better at night, they're less sensitive to pain during the day. That pain is going to be less disruptive to sleep at night. They sleep better at night, less pain during the day, and you get that ball rolling in the direction that you want. So I think that's where I'll stop. That's all I think I wanted to say in my intro, Mark.
Thank you very much, Sean. There's many questions that I'd love to pick up on out of that, but hopefully we'll get around to doing some of them. And certainly I want to pick up on the mental health aspects and your comment that actually it's kind of bi-directional, bad sleep problems, mental health problems, and vice versa. I'm just quickly going back to basics, though. We're talking a lot about insomnia. Are there other common sleep disorders that we need to be aware of?
Yeah, certainly there are. So Brendan mentioned obstructive sleep apnea, which I think is one of the most underdiagnosed sleep disorders out there. So it'd probably be good for us to spend a little time talking about that. Parasomnias, which are a whole family of disorders that are sleepwalking, sleep talking, the kind of violent behaviors that Brendan was talking about, a variety of different things. And then there are probably the next most common one is something called periodic limb movements, which is basically where your little ankle twitches at night, or maybe you get a whole leg kick at night. Usually it bothers the partner more than it bothers the person who's kicking their leg. So there's a variety of ways that sleep can go wrong and create sleep disorders.
Okay, thank you very much, Sean. And we will pick up on a number of those, including the obstructive sleep apnea, and I'd love to talk a bit more about pain as well. Anyway, thank you very much for that. I'd like to now hand over to Jennifer to talk a little bit about psychological aspects of treatment, and in particular the kind of treatments that are being offered by the VVCS to people with sleep problems. Jennifer.
Yeah, thanks, Mark. Of course, in addition to the individual counselling that we provide, as well as couples and family counselling at VVCS, we also have a Sleep Better group program, which people might be interested in knowing about. It's a great place in a group and interactive environment to actually look more closely at sleep problems. And to learn skills and strategies and to, I guess, share knowledge across the group. So it's based on a cognitive behavioural therapy approach. So we're looking at, thoughts, feelings, behaviours. We're actually structuring an intervention to actually address and target specific problems that people are having, or specific aspects of sleep problems. And of course, it's available to all clients or anybody who's eligible, essentially, for VVCS services. And ultimately, it's aiming to assist participants to better understand sleep, to understand the particular type of sleep problem or particular aspects of their sleep schedule, that are causing them problems, and to learn better habits. And of course, the other beauty of our sleep program is that it's available to partners, because we know that it's not a solo problem. It involves the other party as well. It's a shared problem. So really important that partners come along and learn the strategies as well, and learn the same information. I guess, in terms of some of the things that we cover in the sleep program, we invite participants to complete a sleep diary. Really important to get to know what your sleep patterns are and the sorts of things that impact on your sleep. So a sleep diary is a wonderful tool to better understand what it is for you in particular that you find problematic. And of course, from that, it enables you with that information to identify some goals, some things that you might need to change. So, of course, when you set any goal, it's really good to be concrete and specific, and also to stick to your goals. So broad goals are great. I want to improve my sleep, but even more so, I want to change the pattern of my sleep. I want to go to bed at a set time. I want to change my wind down routine. I want to incorporate new strategies, relaxation strategies. So be specific when you set goals for yourself to improve your sleep. And of course, there's some other things that are really important when we're talking about good sleep hygiene. So things like your sleep environment. Make sure it's dark, make sure it's quiet, make sure it's a good temperature. And of course, your bedtime routine. So make sure you've had an opportunity before going to bed to actually wind down, to actually release some of that physical tension that you've built up through the day, or even some of that mental tension or stress that you've got on your mind. Do some things to actually help yourself to release that before you go to bed. And of course, pay attention to your diet and to exercise. Don't exercise too soon before bed, because it increases your body temperature, and we want a lower body temperature before we go to sleep. That actually enhances our sleep quality. And don't eat a big meal before bedtime, really important. Give yourself a good 4 to 5 hours before going to bed to digest the food. But if you're a bit peckish, a little snack's sometimes a good idea as well. Really important to resolve stress, and I think that's come up here today as a factor that impacts on our sleep quality. And of course, counselling is a great place to address issues of stress, learning stress management techniques, or understanding what's underlying the stress, and in some cases receiving treatment is actually really important. Of course, worry thoughts can get in the way of sleeping. We all experience times where we go over and over and over and sometimes ruminate about things that are worrying us. Having time during the day to problem solve and address worries is really important, but also opportunities to challenge ourselves. So asking ourselves, this worry that I'm having, is there evidence for that? What would a friend say if they were in the same circumstance? Is it true all of the time? So some of those sorts of strategies are really helpful. And of course, having a good sleep schedule is essential. So you would have heard about circadian rhythms, heard about the body clock, that idea that we need regularity, and if we don't have that, it affects our sleep quality. So setting a regular time to go to sleep and a regular time to wake up is actually one of the key strategies that actually really assists in addressing sleep problems. And of course, my last point is really about strengthening the association between bed and sleep. So bed is for the two S's, for sleep and for sex, really. But if you're incorporating other things into your bedtime, your time in bed, then you might actually be associating bed with those things. So we really, really want to get that strong association between bed and sleep.
Very interesting. Thank you very much, Jennifer. I'm particularly interested in your comment early on about partners, and I'd love to come back to that with a bit more of a discussion. But I'm interested in when this is a program that's devoted exclusively to sleep.
Yes.
Do you find that if people respond to this and start to sleep better, does that have flow-on effects in terms of perhaps their mood or their functioning?
Absolutely. We know that poor sleep makes us feel irritable. It affects our concentration and our memory. So if we actually address a sleep problem, one of the things we find is that a lot of other problems resolve and people feel much more empowered. So it's not uncommon that particularly in a counselling process, or if somebody who's done the sleep program actually feels a lot better after doing that and can address some of the other issues that might be bringing them to that to the counselling setting.
Which builds on something I think both Brendan and Sean mentioned. So, okay. So now we're going to open it up for questions. And as I said, we've received a lot of questions from you already, and there's still some coming in. So thank you very much for that. We'll get through what we can. I thought that perhaps we'd start with perhaps going back to some of the causes. And we've had a couple of people, Margaret from Canberra and also Rosemary, also from Canberra, actually, asking about the role of military life and particularly deployments in terms of disturbing sleep patterns and whether that in some cases might be the genesis of ongoing sleep problems. I was wondering, Brendan, if I can throw to you, I suppose it would be true to say that on deployment and possibly military life generally, there are a number of disturbances to sleep routines.
The Tully example I gave earlier was a great demonstration where I think we were getting a couple of hours sleep a night, if that. There was another exercise I did many years ago to a place called Macrossan where I was on a 12-hour shift, but because of the noise of helicopters and other military equipment going around, my sleep 12 hours, or my downtime 12 hours, ended up being about 3 to 4 hours of broken sleep. I survived 3 weeks of that. I absolutely survived that. And then recall my roommate, when I got back to Townsville, saying I slept for 16 hours straight. He couldn't rouse me at all. I was out, gone. And that's normal. When I go on a deployment, my expectation is that you will work until the job is done. Because it's a deployment. It's, depending on the threat of the environment you're in, there's a lot of stresses and things that come into that as well, of course, family back home and things. But just the actual service in the place that you are. Sumatra was a good example. We hardly got any sleep there.
So I guess for some people, and you're kind of implying that you were able to manage it most times, for some people readjusting after that is okay. For others it's more difficult. I mean, would it be true to say that people develop bad sleep habits from things like that might then persist as time goes on?
I think that's absolutely true. But you have to do what you can to sleep in those sorts of environments, and doing those sorts of things is not necessarily adaptive when you get back home and you're trying to readjust to a normal life. The other thing that I think that gets really messed up is something Jennifer was talking about, which is the circadian rhythms. So our body clock that tells us when you're supposed to be awake, when you're supposed to be asleep. You fly somewhere, you're jet lagged, you start doing deployments at nighttime often. Your circadian rhythms get very confused, and they don't actually know when it's supposed to be day and when it's supposed to be night, and that does not adjust quickly when you get home. So lots of these things will conspire to take the sleep problems that you're maybe just dealing with on deployment and exacerbate them once you actually get home.
Yeah. Okay. While we're talking about causes, I would like to just very quickly come back, if we could, to OSA, because as you said, it is important, and I think just to make sure that everybody's aware of what this is and what signs to look for and maybe what to do, can you just give us like a couple of sentences on
what it is? Yes. So obstructive sleep apnea essentially is when you stop breathing at night. And what happens essentially is that you have your airway and obviously the airway in the throat, and the airway will start to close very slowly as either there's excess tissue or gravity is pulling your tongue back as you're lying on your back. Whatever it is, the airway will start to close. As it starts to close, that's when you start to get snoring. And then when it closes all of the way and the snoring stops, you're literally not breathing. And the only way to start breathing again is to wake yourself up and start breathing again. And then as soon as you fall asleep, it all starts over. So the signs and symptoms are snoring, somebody else saying, hey, you stopped breathing while you were sleeping, morning headaches, dry mouth, some things like that.
Okay. And treatment is relatively straightforward, is it? Oh, no, perhaps I'm lying there. But you were saying, Brendan, that you haven't got round to doing anything about it.
Well, actually, what stopped me was I had some dental work that needed to be done, so I had to wait for that to be finished. But what they're going to do, I can't remember what the implement is called, but I have a mild sleep apnea, and they've informed me that I need to get a special mouth.
Mandibular advancement
That
device.
one, what he said.
Yeah.
I need to get one of those built by the dentist because medically covered in the Defence Force as we are, and trial that because I do exactly what you just described. My partner picks up on that. There's a certain direction if I lie in bed that she kicks me the other way because, well, A, the snoring is annoying the hell out of her, and B, I'll probably end up starting the apnea symptoms to that closure.
I was going to say, so she's quite useful in making sure you breathe again,
Yeah,
which is quite
sure
helpful.
I'm still alive because of her, yeah.
The other, am I right in saying the other treatment is CPAP, is a mask?
Yeah, that's right. So something called continuous positive airway pressure, which is a mask you wear either over your nose or your nose and your mouth, blows air down the airway all night long. Works great, very hard to get used to. So adherence is a problem with CPAP.
Okay, but anyway, if that rings a bell for anyone, do something about it. Let's go on and talk a bit more about mental health, and I really want to come back to the question of nightmares because, as we've said, this is so inextricably tied up not only with PTSD, although by no means everyone with PTSD has nightmares, but a lot do, and of course sleep. Do you find, Jennifer, in terms of people presenting to VVCS with PTSD, are nightmares and sleep common kind of problems?
Yeah, absolutely. Particularly where there's indicators of PTSD, there's often nightmares, and it's often a problem. It causes lots of wakefulness, really hard to go back to sleep. And you know that feeling or that association that goes with bed as being an unsafe place because they're remembering things, being prompted in their sleep to remember things that that are extreme or horrifying or upsetting, distressing.
So actually being frightened to go to sleep because of the nightmares sometimes. Yeah. I guess one of the things we struggle with often in mental health is the order in which we treat things when people have multiple things. And I guess when we're talking about treating nightmares and sleep disturbance, is there any point in trying to treat the sleep disturbance without treating the nightmares first? Or have you got any thoughts on that?
Yeah, so I'd be curious what you guys do clinically, Jennifer. The data suggests now, actually fairly new data suggests that treating insomnia with sort of the gold standard insomnia treatment can have positive benefits on the nightmares, even though it's not a nightmare-directed intervention. There are a few interventions that are meant specifically to address the nightmares. When I've done it in my own clinic, I'll treat the nightmares first and then I'll treat the insomnia. But this new information suggests we may be able to skip that first stage, just go straight to treating the rest of the sleep difficulties, and that will help some of the nightmares resolve.
Well, that's good. And then
I guess for us it's really about checking the effect of our intervention. So making a decision based on a clinical assessment about where we would focus the treatment, and obviously paying attention to the evidence that's available that suggests the best way forward. But then of course if we're providing treatment for PTSD or if we're focusing on the sleep disturbance and providing an intervention directly for that, really checking to see what the effect of that intervention is as we go, really monitoring closely to make sure it's having the effect that we want it to.
Yes.
And closely related to nightmares, I guess, is the sudden arousal, as it were, suddenly waking in fright. And I see a number of veterans who say, I can't remember having had a dream, I just woke up terrified. And I've sort of thought of that when you talk about the fireworks, but that's an experience you've had.
My fiancée and I were talking about that literal thing last night before I came down here, where I would wake up and I know something's occurring. I'll probably be somewhere in the house, but just a general dream where I wake up in a fright. Something big has just occurred, according to me, but I actually have the memory just dissolves as I awake, and I have no recollection of why I'm awake or why I'm standing in that room, but it seems important to me. And I've been in arguments as I've woken up with my fiancée who's trying to get me to go back to bed because I fully believe that what I just experienced was real, but I can't actually tell you what it was because it's dissolved away. And it's frightening. It's difficult because you talk about treat the apnea versus treat the nightmares and things like that. For us as a family, I have to try and focus on the nightmares first and get rid of that because that's the real threat. The physical threat in the house is the most important part. But all the other drivers are actually the things that probably put me in that space. So I think it's
an interesting point, though, isn't it? And as a clinician, I guess we would say that you work with the client's goals. So would you say,
absolutely.
their priorities are probably the most important in terms of...
And we would work to identify those through the clinical assessment at the beginning of any sort of intervention. Yeah. And obviously incorporate those in the plan.
Yeah.
Yep, absolutely.
Yeah. Great. I'd like to talk more about that arousal kind of thing, but I can see the clock ticking over. Time is our enemy today. But anyway, if we've got time, we'll come back to it. I would like to get on, though, to talk a little bit about how we might help people who have sleep disturbances and so on. I wanted to come back before I forget, actually, to talk about partners. So you mentioned the idea of partners coming along. And do you find that they want to come and they find it useful to be part of treatment?
What we find sometimes is that it doesn't occur to them to come because we locate the problem with the individual, and we forget that there's actually two people often in the bed who are affected through the night by this problem. So I guess what we're doing is we're encouraging partners to consider coming, and when we're speaking with the individual, usually the veteran who's wanting to access the program, we're actually raising that with them during that intake call when we're making an assessment about whether this is an appropriate program. To help, we'll ask about partners. How is this affecting your partner? Have they considered coming along? Please let them know that they're welcome to join in, and that it's really important that they access the information as much as you do.
Has your partner been involved, Brendan?
No, and it's funny because she knows more about what goes on than I do with me. Yeah. I really don't have much of a clue about my nighttime sleep routine. Forget the parasomnia stuff. Talk specifically about the apnea and the even the twitchy leg. Whatever that was, I like that one. I would like to just have that one and nothing else. But I have no idea I do that stuff. What would I know? And I don't remember anything. It all dissolves away anyway when I do wake up. But my partner didn't really know what pathway to take until I became involved in this group, and we realised that there's an opportunity there for her to actually get the help she needs for us as a family. And she needs it more than I do because I'm sleeping through most of it, roughly. But
I think it's interesting, and it's probably a general comment about us as clinicians, that when we're trained, we're not often trained to think about bringing the partners in as well. And I think we probably should do it much more than we do, actually, even beyond sleep. Can I just turn to you, Sean? Am I right in saying you're doing some research on this at the moment about whether...
Yeah, absolutely. So what we're doing is actually picking up on what both Jennifer and Brendan said is, insomnia in particular is what we're looking at, has always been treated as an individual problem. But the reality is the majority of adults sleep with a bed partner. So it's not an individual problem. It's a couple problem. So we're actually testing, we believe for the first time in the world, intervention where we are systematically bringing the partners in, teaching them everything that we're teaching the patients with insomnia. And more than that, teaching the partners how to be helpful supports and coaches at home in order to make sure that the intervention can be more effective and that the patient can actually follow through with the intervention. And one of the interesting things that we found is that partners will sometimes, with very good intentions, do things that undermine the intervention if they don't understand it. So, for example, they may say, you had a really bad night of sleep, why don't you take a nap today? Or why don't you go to bed a little bit early? And those things are completely opposite of the treatment recommendations. And so simply providing that education to the partner not only can help them feel like they're getting some help, but it can help empower them to help the client to actually get better quicker.
Would I be correct in saying, because I know in my relationship we do struggle with the nighttime regime draws problems into our daily lifestyle, and is that the common thing that you see, that families are having real difficulty just because of the nighttime stuff?
Yeah. Well, partners are often being woken. You've described that experience, and so they're often they have their own sleep disturbance as a result of being exposed to what's happening in the night with their partner. So they've got their own impacts, as well as perhaps not understanding what's happening. And you raise a good point, Sean, about making sure that they have the information, but part of the program and supporting the change.
Yeah. And we found, to speak to the point, Brendan, we found that about half of the partners are changing their own daytime routine to compensate for the sleep problems of their partner, which is a huge number. And you think of the daytime impacts and the social impacts and the economic impacts of doing all of that. So I think it's, just to reiterate the points that have been made, it's so important for partners to become involved in the treatment to the extent that they can. And it's going to have lots of positive knock-on effects, I think.
Good. Yeah. Okay. It's a very, very important take-home message. Let's move on to the kind of treatment that I suspect a lot of people are getting, and I'm not sure whether it's any good, and that's medication. You talked just at the end there about some meds, but have you not been trying medication throughout?
So over the year or 2 years, I guess, that I've been seeking treatment, clonazepam was brought up as an option, half a tablet, a full tablet, and things like that. And it needs to be an integrated process, and I don't think I've managed to achieve that yet. So recently what my partner Kim has found is when I take clonazepam, I'll get the language right eventually, when I take that drug, I still have the parasomnias and I'm harder to wake out of them. So it becomes even more stressful for her because she can't control me back to going to sleep. But it is coupled with, you talk about the goals that you mentioned before, those things and the changes, each one of those changes, the medication works if it's an integrated package, I think.
A very, very important point, I quite agree, but on its own, probably not. What does the data tell us about meds as a treatment for insomnia?
So the data tells us what you suspect is true, and that is medications, particularly for insomnia, are not meant for long-term treatment of insomnia. They're really just a Band-Aid that helps you sleep tonight. The behavioral interventions, the thing that Jennifer was talking about at the very beginning, those are the things that can fix the insomnia and can give somebody the skills to fix their sleep again if it goes awry down the road. Medications can't do that, and importantly, what we know is that medications don't have long-term benefit, even if they're working tonight, whereas the behavioral modification sorts of interventions do have long-term benefit.
I actually heard someone suggesting the other day that we've got it kind of back to front, that often people don't use medication in very acute disturbance because they say, oh, it'll pass, he's just recovering from this, it'll pass. But when it gets to chronic, they do use it, and it should really be the other way around.
That's right.
Perhaps, use it to settle quickly but not the long term. Anyway, okay. So something to bear in mind, although I know that it is very tempting if you're given some benzodiazepine, temazepam or something, it's very tempting to keep taking it, but perhaps not the best in the long run, I guess. What about other drugs? We've had a number of people, actually, Caroline from Morwell and Jane, not sure where she's from, asking about the impact of other drugs and things like alcohol and cannabis, for example, on our sleep. Did you use alcohol as a way of managing?
I'm glad you didn't ask me if I use cannabis. With no drugs policy in the
exactly.
Force.
Yeah. So we'll say no.
Everyone watching that, no drugs.
Yeah.
Okay. I had a lifestyle probably in the late 90s and through the 2000s up until about the age of 37. So I'm 44 now, so 7 years ago, where I had a heavy drinking culture because I would, as a military lifestyle, you quite often go this way. You're away a lot. So we'd be doing 2 weeks away, that trip I said for 3 weeks. I'd be planning the next field trip, which would start a week after I got back, while I was on a field trip, because high tempo, more with less, all that sort of stuff. So myself and many of my colleagues would have a drinking culture in between. When you were home, that's kind of the lifestyle you lived. Now, perhaps that suppressed some of my nighttime behaviours because, if you're going out drinking, you're going out to the wee hours of the morning quite often. And it's interesting because I've never really thought about this until now of what that might have meant. But it probably does have an impact. The thing is, your lifestyle is not great when you have a heavy drinking culture. So I think we were talking about earlier about bringing in other medical problems and medical conditions associated with it that drive a lot of this stuff.
Well, again, it's the kind of package of treatment, isn't it, rather than assuming you just do this and fix everything. A lot of people you see must have problems with alcohol.
Yeah. And I guess the problem with alcohol and sleep is that, it makes you sleepy, so it's reinforcing. You can actually go to sleep fairly well at the beginning, but through the night, of course, your body's metabolising that alcohol and it leads to a restless sleep. So you don't get those deep, restful sleeps that Sean was talking about earlier. So, of course, so it creates a dilemma. For people, and from a longer term point of view, creates some real problems for ongoing sleep.
Which I think where I got to when I sort of moved away from the drinking culture, I never had great night's sleep when I was drinking a lot. I never did, but I was always working really hard, and then my body was just probably absolutely fatigued from the physical lifestyle I had. But when I shifted away from that to a more desk-bound lifestyle, more mentally focused lifestyle, the alcohol wasn't doing any favours, and then I got rid of that. I had the long-term health problems of probably drinking for too much for too long.
Yeah, no, that's a good point. Present company accepted, of course, but there are veterans who are using cannabis. Do we know anything about the impact of cannabis on sleep?
We know a little bit. There's not great research with respect to cannabis and sleep, in part because it was, for a very long time, hard to get well-controlled doses of THC in the cannabis. What we do know when you start to aggregate things together, and this is always a tough question, I guess, for me to answer because of what I'm about to say, in low doses, cannabis actually seems to have some benefit on sleep. It reduces anxiety. It helps you fall asleep a little bit faster. It actually gets rid of, this could be good or bad, but gets rid of some of the REM sleep during the night, which for some people might mean reducing the opportunity for nightmares. However, in heavy doses, cannabis has the exact opposite effect. It actually creates anxiety. It creates restlessness. It makes it harder to fall asleep. Your sleep is more shallow and restless. So there seems to be sort of this tipping point with cannabis. All of that is said with a bit of an asterisk that the research is not great in this area, but that's the basic message.
Yeah, sure. Okay. Let's move on, talk quickly about technology. We hear a lot about how mobile phones are kind of taking over our lives and screens are taking over our lives. Is this something that you address in the group as something people need to be careful of?
Absolutely. As part of the education about sleep hygiene, people are encouraged to turn off their devices before bed to allow time for their brain to switch off. We're a 24/7 society now, and it's really hard to disconnect, but for sleep it's really, really important. And I think there's something about the blue light that has an impact, and there's some more in the media about that. Sean, perhaps you have more information about that.
You're absolutely right. I mean, not only do devices wind our brains up and make it hard to go to sleep, but the light, the mobile devices emit blue-enriched light, and that blue light is actually the most active part of the light spectrum, and it actually tells our brain it's daytime. And it actually suppresses the chemicals in the brain that help put us to sleep. So you're actively working against yourself when you use those devices at night.
And I guess goes without saying, apropos the question that came in earlier about playing computer games, partly we shouldn't be doing it in bed because we reserve bed for sleeping.
Yes.
But generally speaking, screens just before bed is probably not a good thing.
Not a good thing, correct.
Yeah,
Yep.
yeah. What about other technology? My kids have apps that will tell them whether they're asleep, and they kind of map their sleep architecture. Are they any good, do you think? Are they useful? Sleep tracking devices or?
Sean's face is priceless, right?
So the question always becomes, are these things validated to say that, yes, indeed, when they tell you you're asleep, you're asleep? And the reality is all of the phone-based apps, you put them on your pillow or your nightstand or whatever, none of them have been validated at all or been shown to work at all. Flip side, though, if you take something like a Fitbit or a Jawbone or one of these commercial devices that do more than just sleep tracker, they're actually not too bad. So they're pretty good at telling you whether you're asleep or awake. Not 100% accurate, but they're almost as accurate as our much more expensive research-based devices that do the same thing. Okay. So the Fitbits, the Jawbones, again, there's caveats to all of that, but in general, they're actually not bad.
Right. Okay. And then what about, have any of you come across any, I guess, insomnia apps? I'm thinking treatment kind of stuff that people might be able to use. And any that you'd recommend?
The CBTI coach, and I think the information is going to be available on our website about that. That's actually a really, really good app. It's got lots of really good information about sleep problems, about sleep hygiene, and options to, it's actually got a sleep diary built into it, so you can actually program in the details of your sleep. And if you're wanting to reset your clock and reset your program, you can put that information in as well, and it sets reminders. It's sleep time now, so on and so forth.
And would be particularly useful, I guess, as an adjunct to one of your groups or treatment generally.
Yeah, absolutely. Yep.
Yeah. Okay. All right. Well, I'm afraid the clock is ticking over, and all those questions, well, not all of them, but many of the questions that I wanted to get to, we're not going to have time for, so I do apologise for that. But I'm afraid the clock is ticking and we've kind of just about run out of time. And so before we wrap up, I would like to ask each of our panel members whether they have any final comments, any take-home messages, anything that they'd like to leave people with. So I might turn to you first, Brendan. Any final comments?
I guess the main factor for me, and we've discussed this on occasion in the last couple of days as we're preparing for this, Outcome driven is where I'm at. I need an outcome. I need to change my lifestyle. I need to change the lifestyle surrounding my family to get that partner support. And it has to be driven by me. All the medical help in the world is useful and has really provided me with the tools and resources that I require. But I still have to own the problem, and I have to own each element of it. They take the old adage of one bite of the elephant at a time to eat the whole elephant. Yeah, absolutely. So I'm focusing on certain factors to try and reduce the threats that I have in my lifestyle towards my family at night and things like that. And the end result, the outcome I want is just a normal night's sleep with perhaps a little bit of that leg kicking. I'll go with that. That'll be good.
Yeah, it sounds good. And I like your point about you need to own the treatment. It's your recovery, you need to own it, which I guess is a different philosophy to the one that we had for so long, which was I'll go to the doctor and the doctor will fix it. So good. Thank you very much, Brendan. Sean, any final comments you'd like to leave people with?
Yeah, I think I would just remind people that, sleep difficulties can be very stressful. Sleep difficulties clearly have impacts during the day in your mental health, in your physical health, in your long-term health, but they are all treatable. And we have evidence-based interventions for just about every sleep problem that is out there. And so don't feel like the sleep problem is just part of life. It's just part of getting old. It's just part of having pain. That's not true. You can sleep well no matter what your condition if it is addressed and treated properly. And I would encourage folks to keep that in mind and not take bad sleep as just part of life.
Good advice. Okay, thanks. Jennifer, any final comments from you?
Well, just to sort of build on what Sean was saying, really, and that is that, there are a lot of positive effects of counselling, individual counselling, couple counselling, and, of course, family counselling where appropriate. But, of course, group programs are really effective as well, and we get lots of really positive feedback about the benefits and the experience of a group program. So I guess I encourage people to consider those options, and like Sean was saying, not to sit on it, to actually do something, be proactive about it, and of course VVCS is there to help.
It's got to be the big take-home message, isn't it?
Yep.
Do something about it. It does help. Okay, on your screen or coming up shortly are a number of resources that you might be interested in, and you don't need to worry too much about jotting all these down. VVCS will send out these resources. There's some very good stuff there, and I'd particularly give a mention, I guess, to the At Ease website, which is the DVA website. It's got some great information for veterans, for their families, for providers, and so on. So that's always a good one to go to. But there's plenty there that are also particularly good. And of course, it goes without saying that VVCS is always there to support serving members, to support veterans and their families. So don't hesitate to get in touch. Finally, I'd like to thank you all very much indeed for participating in today's webinar. I've been thrilled with the level of interaction that we've had from you as participants and also from our panel. I've really enjoyed it, and I hope that you've enjoyed it and found it valuable. Thank you for your input. Thank you very much indeed to our presenters, Brendan, Jennifer and Sean. And I'd like to just remind you, if you could, to complete the evaluation before you log out. It really is important in helping us make sure that we're meeting your needs. So thank you again for participating. Enjoy the rest of the day, and goodbye.